We're going to go on a bit of a journey. And I think probably what I'm going to talk to you about will have quite a lot of segues from what you were talking about this morning. So I'm actually an anthropologist by training who then moved into demography as an anthropologist here, originally. My undergraduate degree is from Cambridge. But recently, probably over the last 10 to 15 years, I've done a lot of policy work. And I think a very interesting discussion this morning about evidence versus advocacy. And what I'm going to talk about actually sort of slides across the top of that, because when I did policy work in this country, running the Foresight and working for two prime ministers, my team was really, really adamant that there was evidence and we didn't even do recommendations, but we showed or tried to show government that if the trajectories continued, this is where we would end up. And then it was up to them to put the policy levers in place. This is going to be different, and it's a story and it's a journey I'd like to take you on. And it's going to start very much around care. It's going to be about Europe and long-term care, but then it's going to fold the idea of intergenerational relationships, communities, and then I want to ground it in a project that we're doing in Oxford. We've only just started it, funded by the MRC, which is really taking some of the conceptual ideas, the empirical evidence, and seeing how can we actually do something about long-term care in communities for older adults. So I want to start right at the top. And the story begins in 2019 when I was asked to chair an EU working group, which was looking at developing long-term care. And the idea of this was that there would be academic evidence, which would lead into the EU long-term care framework, which was launched, I think, was launched in June 2022. And our report was going to be launched behind that in 2022. And it was, I think it's this one. That one should be off. And it was funded by the European Union and by the government in Spain. And we started with a lot of evidence, and I'll take you through all of that. And then the story changed a little bit. So let's just very, very quickly look at some slides. This is how we started. This is the country age structure. You have the blue, which is under 18%. I think this is over 60s. And then 23% is the orange. So this was the map we were given. And then there were things like looking at different types of life expectancy, how they varied across the region. The UK, unfortunately, even by then, this is Eurostat data. You can see the United Kingdom is about 5 in because we were still part of those wonderful European statistics. But sadly, we weren't in the European Union itself. So, basic demographic data. And then this, which is what you're all aware of, and that's the health gap. That one of the issues is, of course, that we're pushing back life expectancy. Are we pushing back healthy life expectancy at the same rate? The UK actually does quite well there because this is for women and we have a slightly lower life expectancy. This is women at 80, lower life expectancy, but our healthy life expectancy is a little higher. And the other two countries are the two longest lived populations in Europe, France and Spain. And then data like this, which is all about requirement for assistance. And I've just shown you this one slide. This is total rather than just men and women. This is 55 plus, 65 plus, and 75 plus. And it's the orange. It's how many lack assistance. And roughly, this data was saying that about 40%, over 40 to 45% of the European population over 55 felt they lacked assistance as they went into old age. So there we were, all sort of ready to go. This was the report, and this was the team that we were working with. And as you can see, the expert group at the bottom, a very multidisciplinary team drawn from different parts. We had geriatrician, we had Lisbeth, who now works for WHO, very much into human rights, Stefania as well, Giovanni's a sociologist, and Tina from the University of Sweden. So we were a multidisciplinary group, and we set off to do a bog standard demographic report, really, which was going to back. And we took this as our definition. We started actually with a human right framework, and I think the team felt that we had to frame it in that kind of way. So we said long-term care is a human right and refers to support that is needed by persons with a limited ability to care for themselves. The needed support can be provided at home, in the community, or in residential care, and may be provided by formal or informal caregivers. And we also brought in family, friends, and community members. So a very sort of standard frame. And then this happened. Our first meeting was early in 2020. COVID hit and the whole thing sort of fell apart because we couldn't go to the European places to look at examples of long-term care. Obviously, the whole sort of Spanish government was completely obsessed, understandably, with looking after COVID, and as a consequence, wasn't really sort of overseeing us. But that was absolutely fine. For about 6 months, we did very, very little. And then at the end of 2020, a whole series of statistics started coming through, and not only statistics, also opinions that were being expressed. And it completely changed what we decided to do. And although I'm not saying we left the science behind, we definitely moved into a much more conceptual rather than scientific way of thinking, because everyone was so angry about what was happening. And these are scientists, we're not used to doing this, but we felt we had to do something that was really quite pertinent to the COVID situation. So the impact of COVID on long-term care, we know, was absolutely devastating for older adults. The WHO suggested that in 2020, half of all the deaths were care home residents. Around 100,000 older adults died in care homes. Hundreds of care workers also died. We know the UK situation, but it was also happening in other European countries, particularly in Italy, particularly in Spain. And there's now widespread acknowledgement that long-term care homes were underprepared and under-equipped to protect their residents. Across Europe, all communities, and particularly care homes, struggled to protect older adults. And as the time went on, more and more survey evidence came out, suggesting that particularly in that first wave, that refusal to take older adults with COVID into hospital, discharging older adults with COVID into care homes, the movement of care workers, very much something that was happening in the UK, and a general lack of training and equipment. And then this evidence came out, which is the do not resuscitate evidence. So Amnesty International found inappropriate or unlawful use in primary care centres, hospitals, and care homes. And again, particularly in the UK, though we did find evidence elsewhere. And the key thing was, this was without discussion nor permission from older adults or their family. And I think in our discussions, that was the thing that really affected us. I think I, and I'm sure most of you, do believe that these do not resuscitate notices are very important, particularly for older adults. But the idea that you would impose them without even letting their families know that they had them, I think was really very shocking. So, in summary, what we, our first draft, we highlighted that a particular concern was that long-term care systems were underprepared and under-equipped to protect older adults. That we saw across Europe there was an over-reliance on residential care services, that we had underdeveloped and undervalued community care. It obviously varied tremendously within countries, but we felt that was a theme. Lack of informal carer support programs, dominant focus on physical health, and in particular, really highlighted the difficulties of ensuring safe working conditions for our long-term care workforce. And if you will remember at the time, particularly in the UK and also actually in America, there was an outpouring of letters, editorials, and commentaries from all the major professional bodies working with older adults, suggesting that actually there was evidence of openly ageist discourse and that the negative stereotyping, prejudice, and discrimination towards older adults during the pandemic had actually led to worse healthcare and increased death. And I think even eventually here in the UK, the British Geriatric Society also gave such a statement. And in a way, it was just that ageism was just rife in all our societies. So we then thought, what are we going to do? The impact of COVID, as time went on throughout 2021, more and more evidence was coming out along this kind of a line. So we then decided, as I say, we've got to do something a little different. We've got to do something that's going to be a wake-up call. We can't just let this go. So this is, some of this data has been published subsequent this is published in 2021. This is looking at the most worst affected countries, and you can see in particular Spain and Italy were very affected. The darker is are the higher rates of deaths. The UK, however, and also parts of France in particular. So it was sort of a widespread picture. And I just thought it would just be interesting just to take a pause and just show you some sort of retrospective data, because people often say, I work a lot on life expectancy and healthy life expectancy. How has this actually impacted on life expectancy? Let's just look at the age 60s. And you can probably see halfway down England and Wales. I don't know whether you can see that. And the key thing to look at is the line was the life expectancy in 2015. The plus was 2019, and the dot is what happened in 2020. And you can see in nearly every country, and very much if you look at men in England and Wales. Does this have a thingy on it? Oh, I'm looking for a pointer thing. Does it? I don't think it does. Okay. But you can see very clearly that you have the line, and then 2019 life expectancy at age 60 was actually increasing, which is interesting because there was a big debate. Life expectancy across the life course was stabilizing, but actually in our country, age 60, and in most countries, it was actually slightly increasing, and then it dropped back. So in that 1 year, we can see quite a bit. But to be realistic, if we then look at what happened, this is a 2022 slide, and this is looking at what happened within basically a year. And don't go into detail, but you can see the countries at the top didn't do so well, but the countries at the bottom, nearly all of those are European. The UK isn't actually, oh yes, the UK is just the one sticking out, England and Wales. We still hadn't gone back then. But the black line shows how most countries had actually started to go back. And I think the really interesting thing, of course, which is not really part of this talk, but of great interest to you, is obviously the impact of things like long COVID. And if anybody knows of some really good data that can actually solve this question, because there's been quite a lot of papers that have come out which have looked at, well, did COVID stop excess deaths in other areas? There is some data which suggests that because people were dying from COVID, they weren't dying from other chronic diseases. But we know that because of long COVID or the impact of COVID, particularly on the circulatory system and the respiratory system, we may well have people who actually will then have excess deaths going forward. And I think we still haven't quite teased out the long-term effect, particularly on older adults, of the COVID virus. And just finally in this area, this is just quite interesting. So this is looking 2020. Let's look over there. You can see we've got females at the top, men at on this side. And you can see, the difference, obviously, in life expectancy. But you can very much see how there was a definite plummet 2019 to 2020 for both men and women, but at different ages. And we know that women have this 5-year advantage over men. The other thing that a lot of data has spoken about is this healthcare access. And this is from SHARE. And what this is trying to show us is access to healthcare for people aged 50 in Europe during the COVID outbreak. In other words, did mainly look at outcome 2 and outcome 3, outcomes where it was actually postponed and where it was denied. So it's a familiar story to this audience, but it just shows how COVID actually affected access to healthcare. And then finally, we've looked at the impact on the individual, looked at access to healthcare, and this is the impact of the COVID-19 epidemic on informal care. And if we look at this one, this is a really interesting slide. This is looking at caregiving to parents from outside the household. And this is where, in a way, we're picking up more of the intergenerational story. And you can see a tremendous increase in children in particular caring for their older parents during the pandemic. So we decided that what we were going to do was take our empirical research, but make it into something that had a far more of, I suppose, a story behind it. And we came up with this idea of the long-term care empowerment model. And the reason we looked at empowerment is that if you look at healthcare and children, when we care for children, we try to empower them. There's a lot of work, obviously, around patient care and empowering the patient. But typically, at the end of our lives, when we're looking at long-term care, people don't talk about empowering older people through long-term care, empowering older people as they approach death. And we felt it was really important that this was a wonderful opportunity to say, no, let's take the framing. It's a human rights framework still, because that was already there, but let's make it much more around this concept of empowerment. We took a rights-based approach. We said our long-term care empowerment model will bring long-term care for older adults in line with the recognized healthcare empowerment approach, which we felt it was not there. Our vision of care focused on realizing individual and societal goals of dignity and well-being, rather than just solving care needs or meeting growing deficits. We wanted to promote the value of care work. We also felt this was a very good time to do that, and of family care in particular. We wanted to have equity at the core of our care systems, and in particular, we wanted to combat ageism and have person-centered universal access to and continuity of care. We had 4 conceptual pillars: autonomy, the ability to live according to one's choice on an equal basis with others and to exercise choice and decisions. Independence, the ability to keep control over one's life. Co-production, this is the difficult one. It's an equal and reciprocal relationship between clinical and non-clinical professionals and individuals using care services and their families, carers and communities, whereby information, decision-making and delivery are shared. And then finally, this concept of empowerment. It's about supporting people and communities to take control of their own lives and the decisions when required. And it needs to sit alongside full engagement, whereby people and communities are involved in the design, the planning and the delivery of health services, enabling them to make choices about care and treatment options, etc. I would say that when we have presented this, and we've obviously presented it, we presented it in full in June last year, and then again in Brussels in 2022, and since then at several WHO meetings, and it is the caring profession, the carers, who've pushed back. And they have said, this is going to make our life really difficult. We don't want older people and their families to be empowered. That's just a different side, and there are probably many people sitting here thinking exactly the same, but this is, we still stand by this, although we do acknowledge this is not easy, and I'll come on to that in a minute. We use the WHO enabling supportive environments as our sort of main frame, so that it sort of fitted in with that WHO work, and as you know, WHO also have produced their long-term care framework, and in fact 2 of our team went and worked with the WHO on that. And these were the goals: empowering older adults, dignity and autonomy, promoting healthy aging, and enabling inclusion and social participation. And then we used the ICOPE framework, because again, we wanted this to fit into sort of recognized framings. And that's the idea that at the macro level, we need development and improvement of long-term care through appropriate legislation, governance, sustainable financing and collaborative leadership. And in our report, we have a chapter on each of these. We looked at the meso level. How do we build capacity in the paid and unpaid workforce? The importance of training, support, and working conditions. And then at the micro level, establishing an effective digital infrastructure. And as the more we thought about this, we wanted to have community-based, intergenerational space, but also recognizing this is the 21st century and bringing in the digital alongside that. But we also were very upfront that we wanted to combat ageism, elder abuse, and mistreatment. We called, this is where we became advocates, which is to say, in the past we haven't done this, to strengthen policies and legislation. We felt there should be educational interventions. We wanted to promote intergenerational contact, and we wanted to raise awareness. We also wanted it to be person-centered, and this is obviously nothing new. Person-centered care is very much at the forefront of many thinking now in long-term care. Again, empowering older adults, collaborative relationships. And this was really important, and this really came out in the evidence. We needed to support people with long-term conditions to have the knowledge, skills, and confidence to manage their conditions effectively in the context of everyday life. And we did some quite interesting work looking at when was it appropriate for older people to take control of their illness. Some people didn't want to do that. Some people wanted to. And it was a matter of building trust on both sides so that the profession would trust the older person and their family and vice versa. So there was some really interesting thinking around in that space. This was really important, supporting families and local communities to provide care. How could we actually engage them in the design of care services and empowering them? And we wanted to build on local community strengths. And the reason I've sort of stressed all of this, because obviously you could read it in the report, is that I then came back to, I was living in Oxford, but I then came back and thought, well, how in Oxford can we do this? Here we are, we've got all this data. We've done some really interesting thinking. We've got a nice, quite conceptual report. It sits alongside the EU long-term care sort of framework. How could we actually do this on the ground? This is where the second bit of the talk comes in, because it's when I came back to Oxford and thought, how can we develop in practically this model in the UK? And so we got money, first of all, from the Helen Hamlin Trust, and then just recently from the MRC, to try and take some of this thinking and say, how can we actually practically implement this on the ground? I'm not going to go into the context. You all know it about social care. We know there's a massive expenditure on social care in the UK. Another policy thing, last week I was at number 10 at the policy unit. Suddenly, they've become very, very interested again in social care, adult social care, which means that something is obviously bubbling again. But I'm sure many people in this room know we've all been talking about this for about 10 years. But definitely social care seems to be something that they're interested in. And I know both the Cabinet Office and the Department of Health and Social Care, and I'm sure Carol knows this, has been involved, are also very much sort of trying to explore different types of models for this. So this is what we then tried to say, well, what is our policy challenge? So our policy challenge still sits within the general challenge of population aging. So how can we ensure resilient individuals and resilient societies in the light of individual and population aging? Coming down, how can we facilitate health and well-being across individual life courses, while at the same time reducing inequalities within and between generations? And particularly for us, and this was the one we sort of have motored on, if you then come down to the third level, a key challenge within that context is to decrease the probability of transitioning from one dependency state to another as we age, and to ameliorate the impact of that transition as and when it comes. And that was, if you like, the working model we had in our mind. We wanted it to have intergenerational fairness. We wanted it to fit in with our general thinking about population aging, but we felt transitions was a really interesting way in which we could develop this. And I suppose at one level, we can say, even model our outcomes or some of these. When we come to evaluate this, we can do some sort of outcome research looking at these transitions. So let's move on as we sort of start coming to an end about this intergenerational. Because intergenerational, as Louise said, is something that I and that the Institute have worked on a lot. And we still feel it's a very, very important component of this. And if we just step back and look at interaction between the generations, there's a lot of evidence that interaction between the generations improves well-being and mental health in both young and old. And I think the evidence out there is now very strong. It's on the whole a good thing. Intergenerational living, we know, can promote healthy aging through increasing physical and mental well-being and reducing loneliness for both young and old. And intergenerational communities, real intergenerational communities, because we all actually probably live in intergenerational communities, but we're not directly aware that we do, are built around an exchange of resources between people where each member, young and old, feels that they need the others and that they in turn are needed by them. This reciprocal idea. It isn't just young people looking after old people, it's old people interacting with younger people. So, as I say, that we've done a lot of work. This is my colleague Jakob Hoffman, who has written a lot on this in different parts of the world. And he came up with a colleague called Matt Kaplan, who also was in Oxford, around intergenerational shared spaces. And this is a move from multi-generational spaces, which are spaces occupied by individuals of different generations, which we all live in, to intergenerational communities, where place encourages formal and informal interactions between people of different ages and generations. And we have another project at the moment, which is working with the Royal College of Art as part of something called the Design Age Institute, looking at how we can build communities from a design point of view that really helps this interaction. We then had already started working on something which the Helen Hamlin Foundation, we'd got a grant from them. And this was something called, originally called EPICS. And many of you may be aware of the EPICS centers. So these were set up, first of all, it came out of Onlock in San Francisco, which was an idea in the 1980s, which were elderly persons integrated care systems, very much person-centered, quite unique in the 1980s. And a woman called Helen Hamlin brought them to the UK and actually funded a whole series of them in the 90s and up to about, I think the last one closed probably around about 2006-07. Most of them were in the Southeast and in London, but at the time they were quite unique. Things moved on and person-centered care, this idea of integrated services, etc., became much more mainstream. But the foundation were very keen to really revisit this and say, given the lack of social care in this country, can we revisit EPICS? And our view was, well, EPICS is yesterday, we've got to rethink this. And so in the light of our thinking, which was coming out of the empowerment work, we decided this approach, that we wish to develop a model in the light of current approaches to healthy aging in place, which emphasize the importance of sustained community connections between generations and across the life course. And so we came up with this idea of intergenerational integrated care strategies, which would promote health and well-being and help delay age-related transitions into dependency, frailty, and ill health, which is, if you like, the main sort of theme that we'd already looked at. We then wanted to establish how these strategies may be incorporated into the design guidance, because we do this work with the Royal College of Art, in order to influence future practice in the planning and building of intergenerational communities. And then finally, to work on how an appropriate policy agenda may be developed, supporting intergenerational integrated care strategies as part of the wider health and social care strategy. And we came up with this very, very simple descriptive model. Right at the middle, we have this idea of these intergenerational care networks. We have the life course, but we wanted to bring in not only intergenerational relationships, but things around ageism, social prescribing, confidence and control, which is about education, but the broader education, digital technology, health and social care, the physical environment, and equality of access. And this is nearly my last slide, don't worry. And so this is where we are. We've only just started this project, this MRC project. We're working with 2 other universities on it. And we are taking some ideas around neighborhood networks, which have been very well received in some of our urban centers. And we are mapping the assets. We are looking at whether we can spread this in Oxford and Oxford County. We have very good support from Oxford City Council and from Oxford County Council, that we can take networks that are existing and that we can use those networks, which comprise not only the public sector and the private sector and NGOs, but also bringing in startups and the sort of private sector as well. They're already there. But how can we integrate them and then put them within our models? So the idea is to facilitate person-centered integrated care, providing ease of access to statutory services, support intergenerational relationships, enable social inclusion, and mitigate discrimination. And we're working on this model, and I don't want to go into too much detail because literally, you know, this is only our second month of developing it, although obviously in order to get the grant, we've done quite a lot of sort of conceptual work to start with. And so the idea is to provide a model which is adaptable to a variety of settings, and we can scale it and spread it and make it sustainable, enabling all older people who wish to remain in their own homes and communities in later life be able to. And I just want to do one last slide, and this is a sort of general slide. It's right at the back of our EU report, and it's this. And it just goes back to that idea of long-term care empowerment model. And it talks a little bit about coming out of the COVID pandemic, how we have to frame our work within dignity, respect, solidarity, and empowerment. We have to get away from these deeply embedded ageist attitudes and stereotypes, that it is the shared responsibility of governments, policymakers, care providers, and communities to combat ageism in all its form and recognize older people, with or without care needs, as equally valuable members of their communities. And we end by saying the UN Decade for Healthy Aging, which is now, sets as its first area for action to change how we think, feel, and act towards age and aging. And we argue that it's high time we change the way we think, feel, and act towards care and caring. Thank you.